Good afternoon, and thank you for joining us today for our webinar, Personalized Medicine Transforming Lung Cancer Treatment. My name is Ariana Sibaldi, and I work with the Herbert Irving Comprehensive Cancer Center social media team. We all have been told from a young age that every person is unique. This is true for more than just your personality. Each person has many distinct characteristics that define his or her biology. Given the complexity of the human body, it shouldn't surprise you that the nature of disease when people become sick, from onset, development, course, and response to treatment, can be just as unique from one person to the next. So imagine, what if your medical treatment could be just as unique as you are? Personalized medicine is a new and exciting field and considered to be the future of research. It aims to have treatments tailored specifically to the patient's individual needs based on their genetic information, with the goal of improving outcomes and reducing adverse reactions. With our rapidly expanding knowledge of the human genome, this is steadily becoming a reality. Today we have with us Dr. Halmos, Head of Thoracic Oncology Division at Herbert Irving Comprehensive Cancer Center. He will be giving a short presentation about personalized medicine and its future in lung cancer treatment, followed by a question and answer session. Now, before we begin our presentation, I would like to cover a few housekeeping issues. We are taking questions during the presentation. If you would like to submit a question, please use the question box in your GoToWebinar panel. Be sure to select the option Send to Staff to ensure your question will be seen. We will try to answer as many questions as we can at the end of our presentation. However, if you have submitted a question and we are unable to get to it, we will follow up with you through email. Now, without further delay, I would like to turn the presentation over to Dr. Halmos. Dr. Halmos, thank you so much for being with us today.
Thank you, Ariana, for that nice introduction. Today I was hoping to introduce how progress in lung cancer medicine has transformed how we manage patients today as compared to a number of years ago. 10 years ago, all lung cancer patients were viewed as having a very similar disease, and they were treated with identical chemotherapy programs with modest efficacy. And we've gone a long way since, so nowadays we're able to match much better the best patient for each individual patient to achieve the best outcomes. How we accomplish that is principally based on genes, understanding the genetics of lung cancers, and as I will introduce it over the next couple of minutes, genetics is very important in lung cancer medicine today. Before I actually go on discussing how we got here over the last 10 years, let me just introduce a couple of patients, actual patients from our practices who have benefited from the discoveries that have been made. On this particular slide, you can see a patient. On the left-hand side, we can see in bright yellow large lymph nodes as well as a large lung tumor. These are cross-sections of the patient's chest on a chest CT. This is before treatment, and as you can see, after treatment, these tumors have essentially completely disappeared. Similarly, the next patient, very bulky disease with multiple lymph nodes that you can see in the middle of the chest. A few months after finding the best treatment for this patient, all the cancer has essentially disappeared. Third patient, even more disease, even more cancer over the surface of the lung and in the lung. After starting treatment, which the patient has been tolerating very well, again, complete disappearance of the cancer. Now, these three patients had received three very different treatments. Nowadays, besides chemotherapy, we have three approved agents, targeted agents for lung cancer, such as Tarceva, Xalkori, and Gilotrif. How did we find out which was the magic key, for the treatment for these individual patients? That's what I will explain in the next few minutes. The first discoveries came from about 10 years ago when the first targeted therapies were introduced in lung cancer management. What was understood at the time that the large majority of lung cancers produce a certain protein, the epidermal growth factor receptor protein, also called EGFR, that's present on the surface of these cells. And about 80 to 90% of lung cancers seem to have this protein present. And as medications were developed that can bind to what's called the active pocket of this particular protein and thereby block its function, the hope was that these medications could drastically change the treatment of the large majority of lung cancers. In the initial studies of these medications, including a medication called erlotinib, also called Tarceva, versus a sugar pill. What we noticed, though, is that the benefits seem to be very modest, with a slight prolongation of life expectancy, and only about 9% of the patients showed significant shrinkage of the cancer, much less than what might have been anticipated. And this was somewhat disappointing, but also led to further research to find out why we were actually off target and who were the patients who seemed to be benefiting from these medicines out of the larger pool of lung cancer patients. The first major discovery actually came from a patient's case. This particular patient, a young nurse who was treated with one of these medications in Boston, her case was presented in the Boston Globe as a very interesting news piece, and this was picked up by a molecular biologist who then set up a collaboration with the treating doctor of this particular patient, and they collected a number of cases, and they decided that they could research more why these patients responded to these medicines as opposed to others. And it's been noted that these patients tended to be mostly women, patients who had smoked little in the past, and they might have had a very particular type of lung cancer called adenocarcinoma, and many of them were of Oriental descent. Now, as the gene of this particular protein was examined, the EGFR gene, these investigators noted that there were specific mutations in this gene. Now, what does the EGFR protein do? It's actually a sensor that sits on the cell surface and watches for signals from the outside. And when the signals tell to this protein that things are looking good, it tells the cell to proliferate, to duplicate. Now, when mutations of this protein occur, then this protein doesn't need those signals any longer. It's always active and always tells the cell to duplicate, to proliferate, and that's what causes these cells to become cancerous. But as you can imagine, in such a case, these signals that go towards the inside of the cell, if we can block them with the particular medication that I just mentioned, then the cell no longer gets the signal to go on to grow and actually goes on dying, leading to major responses in the tumors. So the presence of these mutations now led us to be able to identify which are the actual patients who respond to these medicines. And as you can see in key clinical studies, where patients with or without mutations were compared, patients with the mutations had a 70% plus chance of having a major response to, at the time, a medication that was used was gefitinib, which is a cousin medication to erlotinib, as opposed to only 1% of the patients responded to this medication when they did not have the mutation. So 70-fold difference, a huge difference in terms of the benefit from these medicines. Now, one issue since then has become, though, that as you treat these patients with these medications over the long term, resistance can develop. And this is a patient of ours from a number of years ago. As you can see, this patient presented with a large tumor as well as spread of cancer throughout the lung. This patient received all the available chemotherapy medicines, then came to us and went on one of these targeted treatments, the EGFR blocking medicine, and you can see that a year later the patient had a complete response of his cancer, but a year or two afterwards had worsening of the cancer again. The cancer became resistant to the medication that the patient was taking, similar to how you become resistant to an antibiotic if you just take it too long. This particular patient was gracious enough and allowed us to take a sample of this tumor, and we were able to compare the tumor at the time of resistance to the tumor at the time of diagnosis. And what we found is that out of billions of base pairs of DNA in the cancer cell, a single building block, a single DNA base pair was changed, completely, this little typo completely changing the information that was transmitted, leading to a change in the protein, the EGFR protein, whereby an amino acid change, a building block change in the protein, led to the medication, which originally is able to bind into this binding domain of the receptor being the blue part, the medication being this little structure in the middle. With the mutation, now there's a bulkier amino acid at the bottom of this ATP binding or active domain, and now the medication is no longer able to snugly fit in, and the medication no longer works as a result. So one DNA change, one base pair change can lead to complete resistance to one of these medications. Now suddenly trying to use this medication is like trying to put a square peg into a round hole. But such discoveries should allow us now to learn about the ways the resistance has developed and how we could overcome that resistance. And yes, indeed, learning from this information, new medications have been developed, such as a medication called afatinib, also called Gilotrif, which was just approved a few months ago by the FDA. This medication now is able to overcome this resistance caused by this mutation, at least in some patients. In this particular figure, we see forest plots. What you see here is patients receiving sugar pill versus the medication called afatinib. And you can see the change in the tumor size, and patients who are below the x-axis are patients who respond to the medicine. And you can see a large number of patients showing nice shrinkage in the range of 30 to 100% shrinkage of their cancers as compared to the sugar pill, where practically, of course, no patients do better. And this has led to remissions of these cancers, even though the patients did not respond to the first medication any longer for a much longer time. Now, based on the EGFR experience, it was felt that probably there's other types of gene abnormalities that can promote lung cancer as well. And a few years later, a second key gene was also discovered, the so-called ALK gene. And again, this discovery was based on a single patient's case, actually from Japan. This was a young person who had never smoked, but his cancer did not have the EGFR gene abnormality. And the research team decided to look at the entire genome of this particular patient to find what was the major culprit for the cancer to develop in this particular patient's case. And they found that this particular patient's tumor DNA contained what's called the chimeric oncogene, where two normal genes, the EML4 and the ALK gene, got broken up and got kind of sewn together, creating a fusion protein that just doesn't exist anywhere. This is a chimera that now kind of runs amok in the cancer cells, but also allows us to be able to inhibit it, since this ALK gene, similar to the EGFR gene, is what's called a kinase, where medications can be easily developed to block its function. And yes, indeed, a medication was already actually being investigated that turned out to be an excellent medicine for this chimeric problem. And this is a medication called crizotinib. And as this was being developed, it was understood that this ALK gene is abnormal in up to 5% of lung cancer patients. Again, it's more common in non-smokers with very particular characteristics. And in these patients, this medication can lead to wonderful results. And this is one of the first patients treated with crizotinib, also called Xalkori. Again, on the left-hand side, you can see a very large amount of tumor spread through the body. And after the patient takes the medicine, it's like key got turned off, the engine got turned off, and the patient has gone into beautiful remission. And many times these remissions can last for a long time, sometimes even a number of years. Again, a forest plot shows you that now from a number of patients, with each column representing one particular patient, the large majority of them, when they have the ALK gene abnormality, have a major response to this medication called crizotinib, which, similar to the Tarceva medication, is a pill which actually can be taken with limited side effects. Now, when this medication, crizotinib, was compared to chemotherapy for the right patients, for these ALK-positive patients, we can see that crizotinib did a lot better. Patients lived longer in terms of being in a remission. And also, this medication was much easier to tolerate for patients than chemotherapy. Now, similar to the EGFR situation, of course, resistance can still be a problem. Over time, patients can develop resistance to a number of mechanisms, similar to what happens with EGFR, such as new mutations in the protein, leading to the medication just no longer working as efficiently as before. Again, knowledge about resistance mechanisms can lead to new medications. Now we actually have a number of very exciting new medications in clinical development with 50 to 60% chance of working, even though the first medication, crizotinib, no longer works. And these medications are in clinical studies. We actually have 2 of these clinical studies here at Columbia open at the present time. with medications from Novartis and Roche, two pharmaceutical companies. Now, there's been some concern that most of this great development is only about patients who had not smoked with lung cancer, which of course is very important, but it's a smaller fraction of the population of lung cancer patients, with 90% of lung cancers being related to smoking exposure. Now, in those patients, the EGFR and the ALK abnormality are uncommon, but the gene abnormality of the KRAS gene is very common. It occurs in about 20 to 25% of these patients. And with this is the most common genetic abnormality that we can see in lung cancer that we can potentially target. The problem with the KRAS gene mutation has been that this particular protein is very difficult to approach with medications. But the good news is that we have found ways to block the pathway that this RAS protein controls kind of downstream. We can set up a dam downstream of the RAS protein by blocking a protein called the MEK protein. And now clinical studies with MEK inhibitors, such as a medication called selumetinib, had shown that in KRAS mutation positive patients, when this medication is added to standard chemotherapy, patients have a much higher chance of going into remission and staying in a remission for a significant amount of time. And phase 3 studies of this medication are ongoing worldwide, including at Columbia University currently. As more and more knowledge is gained, more and more genes are being discovered that now we can target, and that gives us even more motivation to work harder to identify these gene abnormalities for each individual patient, because they can benefit knowing about what kind of mutations their cancer harbors, because potentially we can target them more effectively than without having that knowledge. So molecular testing looking for the KRAS, EGFR, ALK, and other abnormalities has become routine practice in places such as Columbia University, and the panel of genes that we're testing for is expanding every day. Now, with this knowledge, we're much more able to put the ducks in the best row for each of our patients to achieve the best outcomes, and that's been a tremendous advance in lung cancer management. That has led to the 3 patients that I presented to enjoy dramatic successes in their treatments with lung cancer. This first patient that I showed you turned out to have an EGFR gene mutation. As a result, she was able to go on this medication called Tarceva and has enjoyed an excellent remission for an extended period of time. The second of our patients actually has a gene abnormality of the RAS gene, which is very similar to the ALK gene, but it's so uncommon that it's been identified only in a handful of patients around the world. This patient, fortunately, we were able to find the gene abnormality in, and as a result, she's been able to take the Xalkori medication because it works just as well for the RAS mutation-positive patients as it works for the ALK-positive patients, and you can see this nice remission which continues to last up until today. The third patient is a patient who actually has 2 mutations of both the EGFR and the second gene, the ERBB2 gene. And unless we had understood it, we would not have been able to find the right medication for her. This patient has been able to receive this medication called afatinib, also called Gilotrif, which actually blocks both pathways, both the EGFR as well as the ERBB2 pathway. And as a result, this patient who's received multiple lines of treatment in the past, and we thought had no other treatments left, has been able to enjoy a complete remission of her cancer lasting up until today as well. So as a result, hopefully I've been able to prove to you that yes, indeed, knowing about genes in lung cancer management is exceedingly important, and is something that we do every day for our patients. But let me also quickly cover a new area of interest, and that's immunotherapy. Lately, we started to understand that the way cancers are able to avoid the immune system is that some cancers are able to generate a protein, the so-called PD-L1 protein on their surface, which works as a taser gun in a way. As the immune cells are trying to come in and kill the cancer cell, this particular protein can paralyze the incoming immune cell and thereby block the immune response. Now, knowing about this particular mechanism, we have been able to generate medications, so-called antibodies, that block this interface, this engagement between the cancer cell and the immune cell. And as we block this particular taser gun in its action, we are able to reactivate the immune system to recognize and attack the cancer. And as we've seen now in clinical development, these medications that are being developed are actually effective in a fair fraction of lung cancers, even after all other treatment had failed. This just shows you one example of a patient before treatment with one of these medications. Interestingly, as the immune response develops, initially it can seem as if the cancer grew, but as you patiently wait over time, you can see how the immune reaction leads to the disappearance of the tumor. We are very excited that we have a number of these medications in clinical studies available for our patients at Columbia University as well. And hopefully I've been able to show you that there's been tremendous advance in lung cancer management, both in terms of molecular testing to understand what is the right medication for each and every patient. We're learning about how resistance develops to these medications, and that allows us to develop second and third line, third generation medications. And immunotherapy is a new and very promising avenue as well. With that, I think the hope is stronger and stronger every day, that our patients, even with advanced forms of lung cancer, can have longer and better lives with their disease. Now lastly, let me just show you how you can contact us at the Herbert Irving Comprehensive Cancer Center with any of your questions. And an archived version of this webinar should be available on our YouTube channel in the coming days. Thank you so much.